Assalamu alaikum. Good morning, everyone. I would like to thank our colleague for making this event great with great speakers. I'm going to be talking about red flags in pediatric ophthalmology. And when we say red flag, we mean a symptom or a sign that can indicate an underlying serious condition. Some are apparent and easily seen, and some of them are subtle and easily overlooked. I'm going to be talking about, it's mainly, some of them are repeated after Dr. Khan's presentation, but it's mainly for students and residents. So going through the structures of the eye externally inward, when we see a child with ptosis, we have to be sure if it's acquired or congenital. Some families, they came to the clinic and they don't know. Looking at old photos is very good. Looking at the pupil, if there's any signs of Horner syndrome, and looking at the extraocular motility, if there's any signs of third nerve palsy. It's worth to mention here that sometimes ptosis can be related to a more serious underlying condition. And two siblings, me and Dr. Arif Khan, have reported where they presented with congenital ptosis and they had scoliosis. The youngest child was booked for ptosis repair, and there was a history of the eldest developing an intra-op complication. So when we did genetic testing, the patient had a mutation in one of the skeletal muscles genes, which is called RYR1. This gene is known to cause ptosis and malignant hyperthermia. So taking a careful history sometimes can show you a serious underlying diagnosis. The second comes with lid discoloration, ecchymosis. We have to rule out neuroblastomas. And lid swelling, all of us know in emergency you have to rule out an underlying orbital cellulitis or rhabdomyosarcoma by looking at the extraocular motility, at the pupil, and the optic nerve. Going inward to the conjunctiva, as a reminder to avoid irreversible vision loss, whenever you have a child with melanocytosis or Sturge-Weber, serial follow-up of the pressure, axial length, refraction is important as they develop glaucoma. Conjunctivitis in the newborn also is is an emergency case. You have to rule out corneal involvement as patient might need systemic medication and admission. And the third, sometimes you can have conjunctivitis, part of a systemic disease. So ask the family if there is any other symptoms and examine the child carefully for any other organs involvement as they can have Kawasaki. Going further to the cornea, I'm sure everyone knows the common differential for hazy cornea. I just want to highlight one of the entity that sometimes can be easily missed, which is megalocornea with secondary glaucoma that is associated with one of the mutation in the gene LTBB2. These patients usually present with large corneas, and you will find high pressure, optic disc affected, and then it will be strange to you how come the cornea is clear with all these findings. Why is it important to know this entity? Because you have to examine them carefully, even sometimes under sedation, and look for the lens. If it is subluxated and there is cases of dislocation, these cases management is different from primary congenital glaucoma. These cases need the lens to be removed rather than the classic glaucoma surgery. The other entity that I would like the fellows and residents not to forget is the CHID. There are some cases which are mismanaged by glaucoma surgery, while there are truly CHID cases. And that's why I always remind my fellows and residents when they see a patient in the emergency that they have to do cyclorefraction. That's the key point that can differentiate both entities. Going further to the iris, as Dr. Khan mentioned, we have the classic and iridia. Whenever it's presented sporadic, we have to look for Wilms tumor, and nowadays with genetic testing that identify easily the patients that are prone to that. And the albinism, as Dr. Khan mentioned, we have the two most common associated syndromes. It's strange that sometimes we have a lot of cases following in the clinic as albinism, but nobody did genetic testing. Genetic testing is important in these cases, as some of them might need strabismus surgery or nystagmus. Identifying patients who have Hermansky Pudlak just put you under preparation when you do surgery that these patients are more prone to bleeding intra-op. Going further to the lens, again, as Dr. Khan mentioned, It can indicate metabolic disorders, all of us know the list that can come with lens opacity, but I just would like to highlight two things. One, that cataract acquired juvenile can be a first presentation of diabetes type 1, and the other diagnosis that Dr. Khan mentioned, cerebrotendinous xanthomatosis, where they have frequent diarrhea, and you will not know that unless you ask the family this direct question, as some families will think this is a normal thing in a child. So whenever you have a child who presents with cataract that was not there since birth, I believe it's important to take a careful history from the family, and if there is any other systemic features, it's better to refer the patient to a geneticist to reach a proper diagnosis. The other entity is ectopia lentis, and again, Dr. Khan mentioned the Marfan syndrome and the homocystinuria. Seeing a patient in the clinic and not knowing what is the ectopia is harmful to the patient. You should at least reach the underlying etiology. Now, sometimes patients present to the emergency with acute ocular deviation. If you have an acquired non-accommodative ET, you have to measure the deviation at near and distance. You have to look at extraocular motility, and you have to examine the fundus for any optic nerve head swelling. And if you find anything, you have to image the patient to rule out cranial pathologies. Third nerve palsy is very important, and you have to differentiate if it's acquired or congenital. And it's worth here to mention that one time we had a patient, 5 months old, presented to us with the family giving us a history. They're not sure if the eye is normal. And we admitted the patient. It was not clearly a picture of a third nerve. It was partial. And for one reason, the sedation was delayed one day. We booked the patient for MRI. And the patient had the MRI. It was normal, but the pupil was, during the admission, involved. That time I felt worried, and we referred the patient to a general hospital, and within 24 hours the patient needed ICU admission, turned to have Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome that can present with third nerve palsy. So you never know. Even if you have a normal imaging and you cannot find the cause, it's better to refer patient to a pediatrician for further workup. I'm sure everyone knows the nystagmus, different types, and what do they indicate pathology in the brain. I just would like to mention that whenever you have an acquired nystagmus, especially when there is optic nerve head pallor or swelling, imaging is a must. It's worth to mention here one study that was done by Dr. Khan in Kikesh, where they saw over 5 years, they reviewed the charts, over 5 years for children presenting with acquired isolated nystagmus. And among 26 patients, only 3 had abnormal MRI. Upon reviewing the charts of these patients, they found that all 3 had optic nerve head pallor. I would like to finish with this case. So all of us know whenever we say leukocoria, especially in exams, you will say, I would like to rule out retinoblastoma. But it's worth to mention that retinoblastoma can present in another different way. And we, as a tertiary care hospital, we see a lot of children with retinal detachment. So one of the cases that always I don't forget personally was a child who presented with chronic retinal detachment and was seen, and it was given the diagnosis of end-stage RD, inoperable. And it's the B scan, I'm sorry that it was not very good quality, but he had retinal detachment with subretinal opacities and vitreous opacities. So this patient was discharged and unfortunately didn't come back till he had MITs everywhere. The key point I want to mention here, that chronic retinal detachment or retinal detachment in a child that you don't know what is the diagnosis, the opposite. If you have an RD, you cannot discharge the patient without knowing the diagnosis. Examine the other eye carefully. Call your colleague to examine the eye. Sometimes you have a peripheral retinal lesion. RB can present with chronic retinal detachment. The only way you can know is by serial follow-up for the patient, or sometimes doing imaging. So at the end, I just want to tell you that we are all clinicians. Before becoming an ophthalmologist, we have to approach our patient thoroughly, generally and locally to the eye, and that's the only way we can get to the proper diagnosis and miss red flags. Don't miss red flags. Thank you.